Dr. Andrew, welcome.
Bismillahirrahmanirrahim. Now I'm going to introduce to you Professor Andrew McCormick. He will talk about developing a surgical registry.
Thank you for the honour and privilege of the invitation here. I've really enjoyed my stay both in Cairo and in Alex. It's been a wonderful time and great to share some thoughts with you. So I'm going to talk a little bit about registries. These are my disclosures. I'm involved in a number of registries in both Australia and New Zealand, and given the small size of New Zealand, we often do things in collaboration with our Australian colleagues. So I'm a bariatric surgeon and I do upper GI cancer work as well. So I work on both those sorts of registries, and also the Australia and New Zealand equivalent of NELA, which is the laparotomy audit. I'll use both the bariatric registry and the upper GI cancer registry as examples of where things can go wrong and where things I think are best done. So registries in our setting are really about improving quality of health care. So specifically about the appropriateness of that health care and also the effectiveness. They can also be used about the epidemiology of a disease, and that can be a subcategory, but that can often be a registry in and of itself. So one example is in New Zealand we have our cancer registry, which collects data on all cancers and so gives that epidemiological basis of that, but doesn't go into the treatment or anything like that. So ANZGOSA, or the Australia-New Zealand Gastroesophageal Surgery Association, of which I am the president, started off wanting to be able to look at esophageal and gastric cancer and also gastric cysts. And so initially there was a combined database, and then developed really an audit or a database for these cancers. And that started in 2002, just sort of on someone's laptop in an institution in Sydney. And then in 2010 developed into a more formal database, which enabled institutional uploads from hospitals all around both Australia and New Zealand. However, it really struggled, and in 2017 we actually had to close it as what we were calling then an audit, and really to reframe it and rework it as a registry, and we're in that process now. And I just want to touch on where it went wrong. So it really went wrong in terms of engaging surgeons. So getting surgeons on board, getting a whole capture of all the surgeons involved in these cases. Because for these types of registries you need to get about 95% capture rate. In other words, we needed to be aiming for 95% of all the esophageal and gastric cancers being operated on in New Zealand and Australia, and we weren't getting anywhere near that. It ran into real problems with ethics, and that was not because we were doing anything ethically wrong, but there are a number of hurdles that you have to jump through in terms of ethics. And Australia is very complicated in terms of its ethical process, and I'll talk a little bit more about that. But also dollars. It is very expensive to run these registries, and to be able to raise the funds to these registries and to do them well, you need to get buy-in from stakeholders, and we really didn't have that. And if we didn't have the surgeons and didn't have the capture and couldn't get the ethics, then we couldn't get the stakeholders to pay for us to be able to do anything. So there were some other issues which sort of went deeper, and that was that the purpose wasn't well defined. It's sort of, this whole thing evolved. It evolved from, like I say, one surgeon's computer that he had in his hospital, and people weren't really sure what it was all about. Was it about research? Was it about quality and safety? Some people didn't want to give their data because they thought, oh, then somebody else will come along and write a research paper using my data without really asking me, so they weren't so keen to be involved. And also the data we were capturing, we couldn't make sure that it was correct. We couldn't validate it. We weren't sure that it was systematic in terms of how it was being collected. And it wasn't, we weren't able to report or give any decent information out of this database to those that really wanted it, so the stakeholders. So this is what we should have been doing. So this is, if you like, the importance behind registries and an important sort of structure of registries. So if you look at the bottom is about value add or the value chain for data, and I'll go over this in more detail. But when you capture the data, why are you doing it, what the definition is, how you're capturing it, are you making sure that it's correct, where are you storing it, and how you then analyse it and then send out a report. That second layer is really about the interaction with the stakeholders. So we talked about the hospitals, the clinicians, and the patients, who are the three, or what we call a triumvirate, the three people or groups of people that really matter in terms of having a successful registry. But then also is about the money and being able to engage with all of these groups to be able to develop a revenue source to be able to run these things and to be able to engage with them and provide information to them in a quid pro quo type example to be able to get money from them. And then right at the top is governance and making sure that you have a group of people who are running the registry, who know about registries, know how they work, know a little bit about the science of them. So these are what we think are the 7 steps that underpin a successful registry, and this is all about the data. And the way you get the data is from your engagement with the surgeons and also their patients. But to get that data, you need to do the ethics, and you need to get that step right in terms of what you're going on about. And as I've said, to get that data and to do the ethics, you need money. So it all sort of, all those things sometimes are difficult because you're all sort of tripping over each other in terms of what to do first. So really the first thing that we need to do is define your purpose at the outset. What are you all about? Why are you collecting, or why do you want to set up this registry? And if you've got a decent reason behind it and you're therefore doing purposeful health research and you've got an evidence gap that you want to fill with your registry, that is when you're going to progress healthcare, improve safety, improve the quality of the care, and therefore improve lives. So first things first, you need to have a clear purpose. You need to know where you want to get to. You need to have a clarity of vision, what it's all about, quality and safety. If you're going to engage people like industry, are you going to include data on device tracking? For instance, in upper GI surgery and bariatrics, are we going to include data on staplers and such like? And then people are able to unite in a vision behind that. You then need to be able to define what those data points are. And you need to have a decent data dictionary. You don't want too much. It's really a case of less is more. And then if you change anything, you need to do that in a systematic fashion. And then you need to go about capturing that data. And as I said before, you need almost complete capture of that data. So you're aiming for at least 95%. And therefore, you need good systems to be able to do that. And you need to be able to do that, work out what those data points are first before you work out your data collection. Are you going to use paper? Are you going to use an IT system? And the IT system has to follow the data collection. It is often a high workload, and if possible you want to have data linked to other people that are collecting that data. You want to be able to link in with them so you don't have to collect it twice. Thank you very much. You need to therefore then work out that the data that you're collecting is correct. Because if you get rubbish data in, you won't be able to produce anything sensible out of your registry. You need to have internal system checks in your IT system. You need to check and sometimes do audits that surgeons aren't cherry picking the data and only sending you their good results and omitting their complications. Not that we don't trust you. And you need to really ensure that you get that complete capture. The data repository and where you store it is all about privacy. So now in Europe with the new rules about data collection, they impact even on us in Australia and New Zealand, because essentially we can't collect data from a patient if they are in Europe on holiday and we ring them up on their cell phone, because they can't then share that with us while they're in Europe. So you need to be really careful about how you're collecting your data, where you're storing it, and also how you store it as well. Even by collecting data such as when somebody had an operation and what the operation was, there is enough computing power now that if your system is hacked, people can work out who that patient was, even if you don't have any patient-specific data in it. And then you need to analyse your data. And that goes back to your purpose and the definitions. You also need to include risk adjustment, because we always, in our practice, our patients are always the sickest, right? That's why we get the complications, because our patients are the toughest, they're the most complicated operations that we do. So we need to risk adjust specifically for that. And then we need to report that data back to the participants, to our funders, whether that be government, whether it be industry, and that report needs to tick the boxes for those funders. So once again, going back to that link with our funders, that link in terms of decent data in, good analysis, and providing reports that they're going to be interested in. So this is a little bit going back to the bariatric registry, which we did well. So, and we had good stakeholder retention and improving compliance with our stakeholders in the bariatric registry. And we've done that with a few carrots. We give people gold badges, which they can include with their practice if they are high submitters of data to our registry, and we celebrate those sort of people. But we're going to have a few sticks as well, and that may come through using insurance and facilities like that. People like the medical defence organisations who do the indemnity insurance for these practitioners, that they're going to have to submit their data to us to be able to get a good cover. And like I say, registries fail because of the cost. So our bariatric registry, which is the good example, has some subscriptions from industry, it has some benevolent funding, it has government funding from the Australian government. Like I say, it has some funding from the medical defence organisations, from the insurers who provide care in the private practice, and also from device manufacturers. And that's because our bariatric registry costs $1 million Australian dollars, so when we put that in, probably about 800,000 US dollars a year to run. So and it's expensive job. A little bit more about the ethics. Australia has actually just changed, but there was at one point, there are 164 ethics committees in Australia. So we had to go to every ethics committee and ask their permission to collect data from their hospital. A very laborious, repetitive process. Every ethics committee wanted their own little change in the protocol, and that would take on average 86 days every time we submitted to an Australian ethics committee. The maximum number of changes that was requested from one ethics committee was 67, and That cost in salary alone about $180,000 to have someone full-time going over all these ethics applications, which worked out about $3,500 per application. In New Zealand, we have one ethics committee, a lot simpler than the Australians. I touched on this a little bit before about privacy, but every jurisdiction is different. Like I say, even de-identified data is now potentially re-identifiable with all the computing power that's out there. This touches back on that machine learning that we spoke about in terms of decision making. But it makes it even more important that only essential data is collected with a clear view of what outcomes we want. Another reason registries fail is poor governance. So we need a framework to govern. We need a multidisciplinary, independent governance body, like a steering committee, who represents all the stakeholders, focus on the task, see where new opportunities lie, and ensure that the outputs and the reports that we provide are what everybody wants. And you also need to have involved an independent custodian who's looking after the data, who's protecting it, who's ensuring the privacy of it. So why do registries fail? Lack of a clear purpose, lack of a framework that is needed to underpin the registry. So going back to our pyramid, there's an Egyptian link to it maybe, and lack of surgeon engagement. There's lots of ethics to consider, privacy considerations. Make sure that your governance is right. And if you get those things right and engage with your funders, then the money hopefully will come. Essentially, they fail if they are evolved rather than planned. And hence why, for our Upper GI Cancer Registry, we've just shut it down and we've started again. And we've started again with a clear plan in mind, not an evolved thing that's come from someone's computer in their own institution. Thank you very much.
Thank you, Dr. Andrew. Any question or any point to be discussed from the floor? Thank you, sir.